Welcome back to Stage Free. We are so excited about our next guest. And I want to give you a little background again about Stage Free. Our goal and mission is to give you, the survivor, the caregiver, the tools you need together to master survival. We want to educate and empower patients, survivors as you go through this journey so you can have shared decision making. So if you watched our webinar with breastcancer.org, you knew it was amazing, but we ran out of time because so many people had questions. And so what we promised is our promise to you is we were going to get Dr. Fox back on and have him on our Stage Free podcast and try to answer as many questions as we could. So the Real Talk webinar was with breastcancer.org and my nonprofit called Armor Up for Life. And so I want to introduce, before we get to Dr. Fox, a little background. Dr. Kevin Fox is Emeritus Professor of Medicine at the University of Pennsylvania, has more than 45 years of experience in oncology, published more than 100 journals and research abstracts, and recognized as one of America's top doctors. Also, Dr. Fox is known for his unmatched knowledge and sincere compassion for treating patients. And we know when we talk patient centricity, compassion is so key for all of us. So, Dr. Fox, thank you so much for being willing to not just join us on the webinar, but now join us on the podcast to get all those questions answered. Thank you.
Thank you very much, Loriana. I'm grateful for the invitation.
I think because it was called Real Talk and you're so real, we really appreciated all your authentic answers. So I'm just going to run through some of the questions. The first, we had a lot in different categories, from whether it was dealing with radiation or anxiety or depression or intimacy. So I'm just going to throw out the first one that asked about, can you talk more about radiation fibrosis? My oncologist, this person says, mentioned lymphedema, but never mentioned fibrosis.
So radiation fibrosis is a very natural response to the insult, if you will, of radiation therapy. Radiation therapy is obviously not a natural phenomenon in the sense that when a woman undergoes radiation therapy to her breast, the purpose of which is to reduce the risk of a recurrence of cancer in the breast, and which is very effective. You're delivering essentially high energy X-rays and other forms of energy to the breast. The body, the tissues respond to that in a very normal, natural way. The tissues are insulted. The cancer cells hopefully are killed. Healthy cells, as bystanders, will suffer for it, and the healing begins. Natural healing of all forms results, in most cases, in this phenomenon of fibrosis, which is a fancy word for scar tissue. And the odd thing, I suppose, about radiation therapy is it induces different amounts of fibrosis in different people. Different people may receive exactly the same amount and type of radiation and respond very differently with respect to the fibrosis they get. So think about it. When the entire breast is given radiation therapy, the entire breast is subjected to the risk of fibrosis, and almost everybody over time will develop fibrosis to some degree, and it actually can be perceived to increase over time. The breast can reduce in size. The breast might become of a different texture. It might become more painful.
Do you feel like this is left out of the conversation, though? We hear a lot about lymphedema going through this, but the warning of like, hey, by the way, if you see this, this is called fibrosis, a fancy term for scar tissue.
Yeah. I think patients are reliably informed that it might occur, but the information I think they are not given is the way that this can change over time, and the fact that they may get it to a less or more degree than somebody else. It's quite unpredictable. Everybody gets some component of it, but its change over time, I think, for patients is the most frustrating thing. When you think of healing, you think of healing has an endpoint where you are back to normal. And with respect to radiation and the changes it imparts on the breast, there is not entirely a back to normal. Now, it may be a slight deviation from normal, or in many patients, it is a significant deviation leading to disfigurement and discomfort. I think that the biggest step that has been taken to try to mediate this problem over time has been the administration of types of radiation therapy or doses that are less harmful to the breast and most importantly, to confine the area of radiation to smaller and smaller areas. For years and years, the standard treatment was to give radiation therapy to the whole breast, the whole organ, if you will, which in most cases is entirely unnecessary. And the most significant research advancements in the radiation treatment of breast cancer, in my opinion, in the last 10 years, have been techniques to provide radiation therapy just to the portion of the breast which is affected by the cancer, which has resulted thus far in equivalent outcomes. In other words, the rate of reduction of recurrence is the same, but the injury to the breast is significantly less. The time commitment to radiation therapy is less. It's all good. Will it eliminate the problem of fibrosis? No, it will not. Well, in the meantime, what can be done about it? Over the years, we've tried all kinds of different administrations, topical therapies. There are topical therapies that can be given during radiation therapy to reduce the acute injury to the breast. Whether that results in long-term resolution of the more chronic injuries, I don't know. But the one intervention that I have found most useful for patients who are beset with swelling and discomfort is actually massage. A lymphedema therapist is perfectly capable of addressing radiation fibrosis in the breast itself.
My sister found a lot of success getting lymphedema, getting a lymphedema specialist.
Yes.
So for those listening, we have a lot of topics we're going to cover, from scanxiety, aromatase inhibitors, weight gain, GLP-1 drugs. So hang with us. The next topic, I do want to jump around to aromatase inhibitors, the hormone therapy. First of all, let's explain. A lot of times people hear it's called AI. It's aromatase inhibitor. It's a hormone therapy. And the number of questions we had about this, from the side effects, the weight gain, the depression, the cholesterol, just to the brain fog, the crying. Talk to me about this, because this is a huge concern when I'm on the breast cancer pages, because I myself have these side effects such as weight gain and depression. There are women who are quitting, and it's affecting adherence because they say, I can't take it, but I know I need it. So can you talk about all these side effects?
Yes.
You just feel validated about it, but what can we do?
Absolutely. So the aromatase inhibitors appeared on the scene 23 years ago, approximately. For many years, the only medication we had to reduce the risk of recurrence of estrogen receptor-positive breast cancer was this drug called tamoxifen. Let's not forget about tamoxifen, because I'm going to come back to that. Several medications were developed which were clearly better than tamoxifen. There were, at the end of the day, there were 3 of them, and they were introduced in succession and used in early-stage breast cancer starting in about 2002. They became the new standard of care for postmenopausal women because they worked better than tamoxifen did. And we began to prescribe them right away, wasted no time in starting this new treatment. It seemed simple. It was 1 pill a day. But we became very aware very quickly of the side effects that occurred. And they are common. They are not necessarily predictable, but they are universal and troublesome. And troublesome such that research has shown that up to 40% or more of patients who are prescribed these drugs will not take them for the prescribed period of time, for a long list of reasons, the greatest of which many people in the audience are familiar with already. Hot flashes, weight gain, joint pain. That was always, to me, that was the biggest one of all. Genitourinary symptoms, vaginal dryness, vaginal discharge, sexual dysfunction. And then the central nervous system problems, the depression, the fogginess of mind. The observations that I've made, or I'm not speaking for myself, but for oncologists who have been around long enough, have simply been, there's good news, and there's good news here in that all of these miseries that drugs will inflict will go away once the drug is discontinued, almost without fail and relatively quickly. But that's not a terrific solution, because after all, then we are withdrawing that very thing which was designed to reduce the risk of recurrence. Well, it turns out that the 3 different aromatase inhibitors, which go by the generic names of anastrozole and letrozole and exemestane, are not identical. And through trial and error, we have been able to observe in many, not all cases, that a woman who finds drug number one to be absolutely intolerable will find drug number two, in some cases, far more tolerable. So my advice to patients is if you are started on an aromatase inhibitor and you find it to be intolerable, don't give up hope. This is where a rational conversation with your healthcare provider comes in. There are alternatives. There are two other aromatase inhibitors which may affect you in different ways. There is an element of trial and error that I think should be entertained. If your healthcare provider is dismissive of these side effects and feels that you should just, what's the proper expression, suck it up and tolerate them, that's not a proper answer. It's never a proper answer. These drugs induce much misery for many people.
I hate being on it. From what I understand, it reduces, I have no estrogen, progesterone, no testosterone. My bones are in pain. I've gained weight, and then we're concerned about the weight gain and inflammation that could, potentially lead to other cancers. So you feel terrible. It affects your marriage because it affects your sex life and your intimacy. It affects your moods. And yet you want to be here for your kid. Like, I want to be here to watch my son grow up. So you're stuck in this complicated situation of, well, I guess I do have to suck it up, which sucks to have to do that.
Yes.
So I can be here for him. And then some people say you got to stay on it 5 years. Some say you stay on 10. Then you talk to friends who quit it after 5 and you hear that now their cancer is spread. And it just plays mind tricks. Like, when do I get off of it? When do I switch? I've talked to people who said, just take it every other day. Now, I know no oncologist is going to tell you to do that.
Right.
But I'm shocked. I'm shocked and yet not shocked at the number 40% of women who are just not going to take it. And I think it's a great idea that you said we should try and say, can I try a different one and a different one? But how do we balance that of, we have these and then we're scared because there's the 5-year or the 10-year, and what do we do?
The thing to remember, among many things to remember, is that aromatase inhibitors have value in reducing the risk of recurrence, even if taken only for a year or two. The truth is that for many patients, not all, the longer they take them, the more benefit they get. But I think striking a balance between what you're willing to suffer for and what you're willing to gain should always be a very personal decision, aided and abetted by proper counsel from your healthcare provider, be it an oncologist or nurse practitioner or physician's assistant or whoever is the most important person in your medical relationship. The dialogue must be ongoing. My own personal bias in this regard, I think most of us are very dismayed at seeing patients suffer at all. When you're doing something which is designed to reduce the risk of recurrence, but that thing is producing great discomfort, both physical and psychological, it is incumbent upon us to look at the limitations of what we're doing. And here I think we justify our decisions by getting into, physicians, oncologists are obsessed with numbers. We like to look at the world in terms of risks and percentages and all of that sort of thing. And many a conversation I have had with a woman who has what we'll call a low-risk cancer. I won't go into the details of what defines a low-risk cancer, but let's just say that if she did nothing at all, took no medication whatsoever, that her risk of recurrence might be 10%. If she takes this medication, it might reduce that risk to 6 or 7%. I think we have to, one of the ways I think it is helpful for some people who are numbers oriented to look at this is, what am I willing to go through for a 3% gain? And put in those terms, many patients will find that this is not worth it to me. And I don't want to take this medication any longer because it's making my life absolutely miserable. And I think, as crazy as it might sound, a responsible healthcare provider should endorse that decision for the patient.
Everybody's not having, just to be clear for anyone listening, this is one scenario you're giving where a particular patient, low risk, may have just a 3% gain. Somebody
Right.
else may have a larger gain. Someone else could have a
Absolutely.
smaller gain.
And there, I think the conversation should be tailored differently. And that patient should be encouraged to try alternatives, to try different methods to offset these side effects. Joint pain and joint discomfort has always, to me, been the most aggravating of them all. How do you remedy that? There is no reliable way to reduce that problem with medications other than prescribing antidepressants of certain types, which also reduce joint pain, which to me, although effective, never seemed a desirable thing to do. Prescribing a second medication to offset the miseries of the first one, to me, never really constituted logical medicine. I think there are analogies in the non-oncologic world. Taking a lipid-lowering drug for your cholesterol. Many of us do it. I do it. Millions of people do it. Why are we doing that? We're reducing our risk of stroke and heart attack by a small percentage. What am I willing to put up with as a human being to reduce that risk from, say, 12% to 9%? Well, I'm not going to put up with a lot. I'm just not. I want to live my life every day. I want to live it symptom-free. And if the lipid-lowering drug I've been prescribed makes me ache all day such that I cannot exercise, that I cannot enjoy myself, I would be among the first to discontinue it.
It's a
After
hard
all,
decision.
that's what empowerment is about.
Right. But it's also scary. Like when my oncologist told me, I think I'm going to feel comfortable you being done with this drug at 5 years. You're having a lot of bone problem. And I'm thinking, I had leukemia. I was separated from my son for an entire year in the hospital with leukemia. I fought so hard that I don't want something to happen to me just because I can't go through all this pain. I feel like I'm just going to have to suffer through it. So I'm here, as much as I despise the drug, I'm grateful for the science, but despise all the side effects. I'm scared to even quit it. So I think this is what so many women are going through. Like, I will do anything to watch my son grow up. And if I have to suffer, I'll suffer. But I also don't want to end up in a bed where my bones are like completely destroyed either.
Right. And no one should expect you to allow the drug to take that kind of a toll on you. This is why I think conversation is so important. This is why I think regular conversations with people who have your best interests at heart are those kinds of conversations, I think, are essential in maintaining one's well-being. This is an ongoing relationship. This goes on forever and ever. We can talk about the 5 versus 10-year thing a little bit. There are actually I won't go into commercial names or things like that. There are tests that can be done on the cancer specimen that you had taken out of you 5 years ago that can actually inform the decision as to whether taking it beyond 5 years is useful. Not everybody needs to take it for 10 years. If you do this test and it tells you that 10 years is better than 5, then you should ask the question, well, how much better? Because it will give you some kind of an idea of how much benefit you'll get. Looking at 5 more years of this misery, if it's caused you misery, is not an appealing idea.
Is this the circulating tumor cell test?
No, it's called the Breast Cancer Index. It's a test that specifically was developed to answer that one question. Is 5 years enough? Is 10 years better?
How do we ask for that? What do we say?
The medical oncologist should be aware of the test, its availability. It's an easily performed test. It requires nothing on the part of you except your consent. The specimen that was removed at surgery is by law kept in storage in most pathology departments, usually for a minimum. In Pennsylvania, it's 7 years, I believe. In New Jersey, it's 10. I could be wrong. At the University of Pennsylvania, we keep specimens forever. That specimen is an archival piece of tissue that is taken out and sent to a laboratory which performs this specific test, which gives you that information about whether more than 5 years is worthwhile or not.
It is powerful. That is powerful. While we're on that topic, and we don't have to go over company names if you don't want, but there's a circulating tumor cell test too. I've seen this at conferences. My
Yes.
sister had it done, and they come and check her blood. And I know this is somewhat of a tricky, controversial issue right now, because I've talked to some oncologists who said, well, if we find out that you have a potential recurrence, where do we look?
Yeah.
Where do you stand on that? And should patients be asking and just discussing this with their oncologist?
Right. So there are differences of opinion, and I'm going to be straightforward with you. I'm very much in the no camp. I think circulating tumor cell assays, or assays looking for fragments of tumor DNA in someone who has had an early stage breast cancer, I think those kinds of tests should still be considered fertile ground for intelligent research, but should not be part of clinical practice. When you stop and think about it, it's really not that complicated to see how complicated it can become if you start engaging tests like that. If you've had an early stage breast cancer, and let's say you had it 3 years ago, and you're taking your aromatase inhibitor and you're feeling pretty well, what do you gain by doing such a test? Well, if you do the test and it shows you that you have circulating tumor cells, what do we know? Well, we know that your risk of a recurrence at some point may be higher than the woman who doesn't have circulating tumor cells, but it does not guarantee that you will have a recurrence. It cannot predict if or when that it will occur, only that it is more likely to occur than in the woman whose test shows nothing. If you get that test result, what do you do with the information? Well, then do you go exploring? Do you do a PET scan or a CAT scan looking for the recurrence that the test says you might have? Yes, you can do that. But it turns out that under most circumstances, that test will show nothing. Then where are you as a person? Where are you with respect to your mental health and well-being at that point? You have an abnormal blood test, the significance of which you cannot define, which to me would be absolutely maddening.
Yes. Well, and I will say that you're not the only one. I've talked to several oncologists from academic centers, NCI designated comprehensive cancer centers, who said no. I still inquired, but I had leukemia before, and they said, we don't even have the science for you. You don't even have your own DNA.
Right.
So I can't even explore
Right.
this opportunity.
No, well, I mean, I don't want to be dismissive of the concept. I don't believe it should be done as part of routine clinical practice and follow-up, but it is one of the most interesting areas of research, and we're doing it in our own institution where women are being, survivors are being asked to participate, and they're having blood and in some cases bone marrow taken to look for these
Circulating
mystery cancer cells.
But but on that topic, the reason why so many women, even on this breast cancer page that I'm on, are so eager to find something, because this idea is, do we hop in the machine? Like for my leukemia, I can go get my blood drawn and they can say, oh, your white count's great.
Yeah.
But for breast cancer, I keep asking, like, oh, I have a pain in my shoulder that's constant, even in yoga. Like, I should not hurt in yoga. Then I'm hopping in a machine, and then it's more radiation. So my doctor's like, we can't keep putting you in the machine. You've had so much already. And what I think, a lot of patients, they have this fear of recurrence, and they said, we don't care how many times we get in the machine. I need to sleep better, or fear of progression. And that fine line of, are you getting too much radiation and being in the scan too many times?
I think this is where I think a rational relationship with a healthcare provider is so critical. Because as a healthcare provider, if we receive the report of a symptom, let's talk about your shoulder, and we see these reports all day, we have three choices, one of which is to leap to the conclusion that you need to know that day if it's a problem or not, and do the necessary test to find out. The other would be, so that's an imperfect thing to do because it results in more testing. The other thing to do is, the other response for us would be to be completely dismissive of your symptom until you don't worry about it. It sounds benign. That's also not entirely responsible. The intermediate solution, and the one that I think works best, is to start a conversation about it in a dialogue. Don't rush to judgment. Shoulder pain, if it is of sinister origin, if it implies something bad is going on, the shoulder pain will persist. If it is a shoulder pain induced by an overzealous yoga session, it will go away. Symptoms that are transient, which most aches and pains are not indicative of anything serious. Symptoms that are persistent should be investigated. Question then becomes, how long do they have to persist before we investigate? Common sense in medicine, I think, says a 1 to 2 week symptom probably should get some attention. And you should do the necessary radiologic test, because you will find out under most circumstances that persistent symptom will be nothing. And I think that is terribly important.
Well, and I will say, after having this go on for months, and I said, I have friends with metastatic breast cancer. I've covered it. And just because I exercise and eat clean doesn't mean I'm immune from, becoming metastatic or having my cancer spread. But fortunately, I found out I have a torn rotator cuff. There's a whole other issue. But I'm so glad I got in the machine to find out, because
Right.
now I'm going to PT.
Right.
But you hear so many times also on the breast cancer pages, when you're constantly with survivors, that they've had this and then they found out that that it spread. So it does play with our mind. And I like how you mentioned 1 to 2 weeks or 3 weeks, but if something persists, and then be your best advocate. And I want to remind people who are listening, when I say survivor, a lot of times people with metastatic saying, oh, I wish I was done with treatment. I wish that you weren't metastatic, but do know that you're a survivor from day of diagnosis. So we are all survivors, whether someone finished treatment or not, and we're here for you. You have the fears of progression, while others have the fears of recurrence. And so I want to get back to Dr. Fox to talk about GLP-1 drugs, because here's what we're hearing. So many of us have gained weight. We feel terrible. It's impacting just how we feel about ourselves. When you don't feel well, adherence goes down. We may not go to our appointments. It impacts our marriages. We're already stressed about finances. You just don't feel good about yourself. And it impacts maybe you getting back out into the workforce. So many things. And then you hear the GLP-1 drug. So I tell my doctor, well, I've gained weight. And while I should be happy I'm alive, I'm grateful I'm alive, but I also know that weight gain and visceral fat can lead to cancer, or can lay the foundation. Let me be clear and say it properly. Like the inflammation of weight gain, that is another comorbidity that can put you at risk. So we're hearing on the advocate side that GLP-1 drugs are somewhat cancer protective and should be really looked at closely for survivors. And I'd love to hear your opinion.
Well, I'm going to back up just one step before we get to GLP-1s and talk about the whole subject of weight, and what attempts have been made and are being made to provide useful information about this issue. Fact number one is that women who weigh more have a higher rate of recurrence than women who weigh less. That is true. Women who gain weight in the post-diagnosis period may or may not have a higher recurrence rate. And there's no refuting that. The next question is, what do we know that can be done about it? Well, there have been sincere attempts to deal with this, and there were, and many people in the audience may know this already, but there were 2 very large, very well thought out studies done in the United States, one of which was called the WIN study, which looked at reduction in fat intake. Breast cancer survivors, one group could eat whatever they wanted. The other group had a very rigorous attempt to reduce their intake just of dietary fat. It turned out to show 2 things. One is that it resulted in weight reduction, and it also resulted in a lower risk of recurrence, which was very encouraging. The problem, and this is always the case, you take one step forward and then you take another step back, as a second study looked at fat reduction and adding additional amounts of fruits and vegetables to the diet. And for whatever reason in that study, which was called the WHEL study, women did not lose weight to the same degree, and it did not show a reduction in the risk of recurrence. This is the frustrating point where we find ourselves in 2025. The only other thing I can say to this issue is that in Germany, there has been ongoing, I think over 10 to 15 years, a study called Success C, where survivors of early stage breast cancer are being assigned to intentional weight loss strategies, much of which involves reduction in fat. The weight of evidence is that losing weight may very well reduce the risk of recurrence. That's where we are in 2025. How do GLP-1s figure into that? Boy, it's tempting to do a very simple experiment, isn't it? Where one group of women gets them and one group of women doesn't get them. The women who get those drugs will undoubtedly lose weight. I shouldn't say undoubtedly. In all likelihood will lose weight. Will the risk of recurrence be lower? It's the perfect research study to do. In the meantime, can we encourage survivors who perceive themselves as overweight to take these medications for weight loss? I would put it this way. If you have reasons to engage GLP-1s other than breast cancer, if you meet the criteria for GLP-1s for other reasons, well, you should give them serious thought. If you are a woman who is of normal weight or slightly overweight and you don't meet the criteria for GLP-1s, then I would personally exercise caution, because as many people out there know, these medications are A, not always accessible, B, can be very costly, and C, it's pretty much, a lifetime commitment in the sense that if you stop using them, the effects will quickly go away. So I think the short answer is it's a ripe area for clinical research, and I would encourage survivors who meet the criteria for those medications for reasons other than breast cancer to have a conversation with their primary care provider about them.
And I will say on that note, I just started last week a GLP-1 because I'm fed up. I talked to my leukemia oncologist, so I have a leukemia doctor, breast cancer oncologist as well, and I said, I gained weight after the full body radiation. Then I got breast cancer. I already knew I was at risk because of the full body radiation. But whatever the reason, I am not going for the trifecta. I eat clean. I work out. I intermittent fast. I do an hour. I do so much. And maybe it's the stress from the fears of recurrence. Whatever it is, I, along with thousands of women, can't lose weight. And if one more person comes up to me and says, well, what is your diet? I'm like, I was a medical reporter and a fitness coach. Don't ask me I know what my diet is. I helped other people lose weight. So I said, that's it. I'm done. I have to reduce my weight. But my oncologist wrote me a note. He wrote a note trying to get it covered, saying this will help reduce not only her risk, what he believes my risk of recurrence, but also increase my natural killer cells from a leukemia standpoint. Because they've never rebounded after my leukemia. And there's been some studies for that too. Crickets from my insurance.
Let me ask you a question, Loriana. Did you have any trouble gaining access to the medications?
Yes. Crickets from my insurance company. I will not name them, but crickets, nothing. So I had to go to a compounding pharmacy, which, again, I agree. People said you don't really know the dose you're giving, and it's very hard to do it yourself. I have so much scar tissue in my stomach. Someone said, well, do it in I can't do it in my arm because I can't do it. It's such a mess. So anyone listening, I feel you if you're trying it. But I found it at a compounding pharmacy for like $270 a month, which I can't afford. But I'm going to find a way if I have to eat, whatever I have to do, because I am going to be here I don't know if I've mentioned it at the beginning of the webinar. I myself have PTSD and depression from being separated from my son, and I'm going to make sure I'm here. And I'm not the only woman who said, that's it. I'm going to try GLP-1 drugs.
I think the part of your story that is, I think, should be given the most attention, well, not the most attention, but is the fact that you had a healthcare provider who was willing to act as your advocate in this regard. We can't say with assurance that these drugs, by reducing weight, will reduce recurrence risk, but logic tells us that it might. And writing a letter of support, although I guess in the case of your insurance company was not successful, was I think the proper thing for he or she to have done. It's what are we here for? We're here to advocate for your best interests. And I think it was it's a shot that you have to take. You have to find out, can I get my hands on this? Will it allow me to lose the weight? Because the weight gain per se is not a healthy thing.
But I just hope this topic gets more tread and becomes more front and center, talking about there's a lot of conferences and a lot of things talking about GLP-1 drugs. And I don't hear people addressing like the cancer community and how we can help be cancer protective. Yes, I know there is a cancer risk for somebody with a particular type of, I believe it's thyroid. You would know that maybe more than me. But this conversation is not really being had front and center when we talk GLP-1, like about the cancer community. And I'm hoping it becomes out there more and that it's okay to talk about. And I do not feel like I am giving in or giving up. I dare anyone outside. I mean, I know you understand me, but I dare anyone to challenge me on why I'm doing this.
I wouldn't challenge you. And I think I can give you reassurance that the GLP-1s are such a hot topic in all of medicine that you will see the cancer community, the people who do research, they're going to embrace this very quickly. And appropriate clinical research to look at the benefits of these medications, I think, will be done in relatively short order.
Hopefully that means that the insurance companies will start leaning in and realizing, hey, if we cover this for this patient, the survivor, we can reduce her risk of recurrence and save we know how much a cancer journey costs. They can save themselves so much more money, but I know this is not the topic today. I know we are almost out of time and I really appreciate it. So I believe we've covered everything from the exercise, the diet. If there's anything else that we did not cover, I know we talked about intimacy, and I do actually, before we go, I want to get back to the intimacy issue. As you and we were talking earlier, that these aromatase inhibitors affect intimacy, and a lot of female patients, if you have a male doctor, like you said, they're not always comfortable maybe opening up and discussing this with you.
Yes, and I found that to be a very relevant issue in my time in practice. When the aromatase inhibitors became part of standard clinical practice, and if you would read the clinical trial results and you looked at the list of side effects, the list of side effects that affected sexual function in some way were considerable. Yet, in the years that followed, I found that I was not hearing those complaints from patients as often as I would have expected. And I was not inclined to try to dredge up those problems if a patient didn't volunteer them. And I realized after a few years that perhaps the reason I wasn't hearing it is because I was a male. 99% of the patients were female and might not be comfortable addressing these issues with me. Therefore, I would encourage anybody out there who is affected by sexual dysfunction to bring it up in a way that makes you feel comfortable. If you're not comfortable confronting a male, then there might be a person in the practice with whom, be it a nurse practitioner, a specialist in survivorship, or anybody with whom you might feel more comfortable having the conversation. Ask them. Don't feel embarrassed to ask them. Don't feel embarrassed to tell your male doctor, if you have one, that it is a question you'd rather address with someone else.
Put it in the portal if you can't say it. Put it in the portal and say, hi, Dr. Fox. Hi, doctor. I don't feel comfortable sharing this in person. Is there someone you can direct me to?
As much as we complain about patient portals, I think this is an area where it is uniquely beneficial because it allows you to ask questions which are personally very sensitive ones, not in person, and you'll get a response, probably quicker.
Yes, I love the portal. I know we could go overboard, and we could do a whole podcast on the best way to address your doctor in the portal. Like make it a news headline, put bullet points. Don't go on. Anyway, I've helped people like this is the best way to get a response quickly. Dr. Fox, you are amazing. If there's anything, I know there's so much we could talk about, and I'd love to have you on again. But is there anything from this conversation you want to address more?
Well, did you care to talk at all about the alcohol question, or
Yes.
Okay.
The alcohol and exercise, and somebody had also mentioned in the webinar that they're still smoking.
All right. Well, let's do those one at a time. Smoking, number one, is never good. There is no redeeming quality of smoking with respect to health outcomes. So if you are a current smoker, please do your best. Find a way to stop. That's the only advice I can give. The exercise question is a great one. I think of all the research that's been done, as hard as it is to do, there is evidence which I consider compelling that women who are breast cancer survivors who engage in reasonable amounts of exercise probably feel better and might very well have a lower risk of recurrence. So the amount of exercise one appears to have to engage in is not daunting. It need not be high impact exercise, several hours per week. I think 2.5 hours is the current number of moderate intensity exercise per week is enough to give you health benefits. Lots of good reasons to do it. Alcohol, to me, has always been the most interesting of all issues because the research, so the one area, the one dietary thing, if you will, that has been researched more than any other in breast cancer is alcohol intake. And it's been going on for years. And the results have been very clear for years. I was very thankful that the Surgeon General finally took, they took it upon themselves to issue a statement recently about this issue. If you haven't read the statement, it is worth reading. It's short, it's well written, and it makes very clear the things with respect to breast cancer that we already knew about. The truth
Can you
is
spell that out?
I think the difficulty is the message is clear, but the difficulty in translating the message to breast cancer survivors is harder because the Surgeon General's reports and all of the research, not all of it, but 99% of the research has been done in the general population, women who've never had breast cancer. It is clear that if they drink even moderate amounts of alcohol, their risk does go up. It doesn't go up very much. And this is why the Surgeon General's report takes great pains to explain this. It explains the difference between relative risk and absolute risk. I won't go into the numbers because that would become boring, but drinking a little bit raises your risk of getting breast cancer if you've never had it. The problem from an oncologist standpoint and from a survivor standpoint is how does that information translate to me now that I've had breast cancer? Does alcohol consumption increase the risk of recurrence? That's much harder research to do, and the amount of research that's been done has not been conclusive. We cannot tell you that becoming a teetotaler, if you were a drinker of one drink a day, whether your risk of recurrence will go down. Logic tells you it might, but we don't have the proof, so we can't advocate it for that reason. What it can do is raise your risk, in theory, of getting a second breast cancer unrelated to the first. Many women are out there who've had 2 breast cancers. They have one this year and then 15 years later get another. It may be possible that alcohol consumption may increase that risk. Am I advocating that you stop drinking? I don't feel responsible uttering that statement because I think, like everything else, it has to be put in context. How much drinking involves how much risk. It may turn out, if you're someone who enjoys having a glass of wine every day, that the increased risk, which is probably 1% to 2%, may not be enough to dissuade you from drinking. And that, again, is a personal decision, which should be personal, but should be made in the context of proper information.
It's all the risk-benefit ratio, which
Yes.
drives me crazy to hear. The risk, the benefit.
Yeah.
I say if you want to have a drink, consider, so many restaurants have mocktails now. The only
Yes.
thing with the mocktail is that there's a lot of sugar in them.
A lot of sugar.
And so then you're dealing with the sugar and the weight gain. So that's a tricky.
Pick your poison, right?
Pick your poison. For me, I drink kombucha, which still has some sugar, but they have low sugar kombucha. And when I go to a restaurant, I just tell the waiter or waitress, hey, I'm living life on the edge. I'd like some sparkling water with lemon, and I'm the designated driver. So that's just the way my life is, because I want to make sure I check off all the things that I'm doing to make sure that I reduce my risk as much as possible.
And you cannot be faulted for doing it. Now, if you're someone whose absolute mental well-being clings on having a glass of wine every day, you may not be so ready to give it up. And that's okay, because the risk at the end of the day is not an enormous risk. I'm not advocating for one point of view or the other. I'm advocating for whatever works for you.
Right. And I love how you say that it's not just the risk-benefit ratio, it's what's best for you. where you weigh the risk and what you need to do to be happy and feel healthy. And it's important. And that's why we do this podcast, because we want to educate and empower patients, the survivors, the caregivers, because the caregivers help make a lot of these decisions as well. So you have the tools to master survival, to make the best decisions, to have shared decision making, that it's not just your oncologist making a decision for you. It's you and your oncologist as a team and your care team, because I call this a team sport. And so, again, Dr. Fox, we are just incredibly grateful and blessed to have you on our podcast. Oh, before we go, I want to say someone had asked what my mantra is. And my mantra is, it's 4 parts. It's I am strong, I am brave, I am healed, I am cured. I am strong, I am brave, I am healed, I am cured. And when I get in an MRI or a PET scan, like I had to do 2 in December, I close my eyes before I get in the machine so I cannot see how close it is to me. I can take a Xanax or something, that helps too. But then I repeat that mantra over and over, and I do breathing techniques until I'm out of the machine. And I ask the technician to talk to me and coach me. I said, look, I work well with positive affirmations. So say, hey, you're doing great. You're doing great. Like, cheer me on. Tell me how much time I have left. And I just keep saying, I'm strong. I am brave. I am healed. I am cured. I'm strong. I am brave. I'm healed. I'm cured. So several people had asked what that mantra was. I wanted to make sure I shared that with others in case it helps you. So Dr. Fox, we are so blessed. I just want to remind everyone, Dr. Fox is amazing. He's had 45 years of experience in oncology, emeritus professor of medicine at the University of Pennsylvania, published more than 100 journal articles and research abstracts, and recognized as one of America's top doctors. And I think it's fair to say for sure that you are one of America's top doctors, and we are all blessed to have a chance to talk with you. So thank you for joining me.
Thank you, Loriana. It's been a great privilege to participate, believe me.
Learn more about Stage Free and catch up on previous episodes at armorupforlife.org.